I think those presentations, firstly, thank you to our speakers for sticking to time. Michael will be most proud that within this session we have stayed to his programme and his organisation, so thank you. I also want to thank you both very much for the tone of the presentations in terms of that welcome for interaction and engagement. I think that really hopefully provides a good opportunity then to create that interactive dialogue, so thank you. I'm going to open up to Mike and Madeline in the first instance, just to respond to the presentations that they've just heard. Mike, do you want to respond first?
Thank you very much. That helps. Hello. Thank you very much. Two great presentations. Thank you very much. Both of them raised lots of ethical issues, and I'll quickly gloss a few of them. So I think the key thing about ADHD specifically and TUE in general is the perception issue. Are athletes taking a shortcut to proscribed substances? That would be a perception. You've both laid out good reasons why you think that perception is not grounded in fact. Len, if I go to you first, of course, any mental illness or disorder has blurred boundaries, and clinical judgment as to whether a person has or doesn't have, and to what degree they may have a mental illness, is going to be challenged in ways that some physical conditions might not be. So there is, in theory, a space which could be opened up for exploitation in a weak system. Now, you've got a fantastic system. And 2 points I wanted to pick out from that. First is the independence of the psychiatrist doing the review. Very strong part, which gives you great reassurance. What's the cost of that? Could that cost be carried through by sport organisations worldwide? I'm probably doubtful about that. You talked about the criticality of the condition of impairment. So you might have symptoms, but if no impairment, no TUE, and that's a very strong statement, a very robust one. What I would like to know a little bit more about is not so much the individual variations of the athlete-patient, but the sports demands. So there's a case in the International Paralympic Committee where I believe it was a wheelchair archer was not given a TUE for beta blockers because it was thought that though the person clearly had the condition, the treatment would so skew the integrity of the athletic contest that the integrity issue overrode the clinical need. And that's a really interesting thing. So do we need not merely judgments about the pathology, the impairment and the athlete, but also judgments about what might this medication do in that sport? And that leads us again against the idea of harmonisation, universality of rules. The second thing I picked up, which was really important, was this idea that if you do need a prescription for ADHD, ADD, a long-acting preparation would be much less likely to usurp the integrity of the contest and give an athlete an advantage. So I thought that looked to me like a norm you might prescribe across WADA, and I don't know how WADA would feel about that. If I move on to Al's presentation very quickly, the criteria, the interesting thing which perked my interest. A significant impairment to health. But I thought nearly all elite athletes, at least in certain sports, already had very significant impairments to their health, and they carry those through into competition very often. So that's an interesting criterion. I mean, an elite athlete once said to me, it's not the best athlete who wins, it's the person who can get to the start line in the best shape. And so I think I think we have to think about health in the context of elite sport. It's not clear to me how one interprets that one. Secondly, again, you've got this idea of a return to normal health. But how are we going to standardise normal health? What norms will we use? And there I think some international classifications would be really helpful. Now, in the retroactive thing, as you very well know, we disagree quite a lot about that, Al. I think about the strictness of strict liability throughout anti-doping policy. And then I look at the retroactive criterion B, which says there was insufficient time or opportunity to get a TUE, so you could apply for one retroactively. All that looks very loose to me. Now, there might be certain cases in which that would be a proper application of the rule, but I wonder how often they are. So the looseness of that really struck me quite significantly. And as you know, again, on the criterion D, that fairness requires the granting of a TUE. Now, I'm a professional philosopher and a professor of ethics. Now, fairness is a very, very contested concept. But I don't know of any ethicists or philosophers on your panels who are making that complex judgment. Now, in some cases, it might be just absolutely smack in your face obvious that fairness demands it. In other cases, it's going to be really difficult to contest that. So I'd like to hear a little bit more about that. Thank you very much.
Thanks, Mike. So I've enjoyed our conversations before the meeting, and we've had some robust ones before, and the questions you just raised are really pertinent, and I think have made me think deeply about the program, and I think that's a good thing, and one of the great things about the meeting. In terms of ADHD being a mental health disorder, you're absolutely right. I mean, in mental health disorders, we are reliant on clinical observation. Our biomarkers are not ready for prime time. It is why the neuropsychological testing is used in cases of uncertainty and is not mandated up front because it is part of the biomarker would be considered a test. And the yield on it is not high enough to mandate on every case up front in the 40-man program. And unfortunately, for mental health disorders, we can't take a piece of the brain like we can take a piece of the liver. And we have to live with clinician judgment, and that's the nature of the beast. That's the way it is. And so therefore, we have to rely on making that assessment as standardized and as best as we can by using clinicians that have expertise in the assessment of the disorder, having independence in the review of their assessments, as you highlighted, training them in using the best tools that we think we have available for it, and using outside sources of information to corroborate the information that's obtained. So we try to obtain information from parents or older siblings about childhood history, or report cards, or things that document, not just retrospective recall. We look for current informants of significant others or the team in terms of current symptoms and impairment. So we do the best we can in terms of making that assessment.
Perfect opportunity, I think, just to bring Madeline in, because we can't take a piece of the brain. We can't ask a horse, about their own medication needs. Could you just bring in a process around equine and how we respond to equine athletes, given what we've just heard already from the panel members?
Yeah, so, it's all fascinating to me from a comparative point of view, and the things which Mike has picked up on are relevant to us as well. So the big difference, of course, between animal athletes and human athletes is the fact that the animals can't consent. And so as veterinarians, our primary obligation is meant to be always to protect the welfare of the animals. But there is, as there is in human medicine, when you have physicians working in sports medicine, inevitably sometimes a conflict, because the vet is, of course, being paid by the owner of the animal, and the owner doesn't necessarily have the animal's best interests at heart. They may just want them to compete and to win for financial reasons. So that's always a kind of underlying conflict. And I was really interested in what you said, Alan, about, at the very beginning of your talk, about what effectively you were saying was the kind of moral basis of therapeutic use exemptions, and the fact that some people in the beginning really just thought there shouldn't be any at all. And that's interesting to me, because in the equine world, broadly speaking, we have a division into the racehorse world and the non-racehorse world. And the racehorse world view is very much that there should be no drugs being used during competition at all that have any effect on the animal's body system. So it's not simply an effect on their performance, but it's have any effect on the body system. So that's actually stricter than your criteria. Whereas in the non, and they view that as necessary to protect sport as well as the welfare of the animals. Whereas in the non-racehorse world, which is regulated by an organisation called the FEI, they do allow certain therapeutic use exemptions in order to try and protect the welfare of the athletes whilst facilitating clean sport. That was interesting to me.
Well, there actually still are people, there's a few, who will say there should be no TUEs, there should be no medications, it should be absolute purity. And there's also people who say that there should be no anti-doping and everybody should be allowed to take anything and everything and have all of the pharmaceutical company logos up and down their sleeves like in a race car. So it's an option, but it's not something that most people would think makes sense to remove diabetics, remove asthmatics, and so on from people with inflammatory bowel disease. Sorry, elite sport's not for you. So but it's an interesting to hear some of the parallels. Sue, if I may respond a bit to some of Mike's comments. For those who don't know, I've been going back years with Mike McNamee and gone to meetings, gone to his house, gone to bars, and we've gone through this many times. So nothing's new here that we'll argue anywhere and everywhere, and we're still friends. And many of his comments have slowly trickled into some of our versions, so we're very grateful for that. Comment. The business about the long-acting ADHD medication, that would be interesting, and I think that certainly they're less prone to abuse, but it's very difficult from a WADA perspective to try and promote a certain medical practices around the world. I mean, most hospital organizations, provincial governments are incapable of guiding physicians in a certain way. So it's a great idea. It's something that I'm always looking at and seeing could that be something that we would allow? But I think in the practical term, it's near impossible across the world. But again, an interesting thought. Just to give a few ideas of the proposed ISTUE changes, and I say proposed because they still have to be accepted by the executive committee of WADA, is the idea of having a clear diagnosis with documented clinical evidence somehow is never actually in the ISTUE. And we went to a CAS case, and somebody was stating they were taking DHEA, which is kind of testosterone precursor, for this adrenal insufficiency. And somewhere we were really arguing the fact that there really was never a clear diagnosis. And someone pointed out it doesn't actually say that. So now we have that. And as we put that in, what we removed, I don't know if you're aware of this one yet, is significant impairment to health, which has been there since 1992. We just X that clause because it becomes redundant, and then I won't have to explain what the hell that means to Mike McNamee later. Nobody ever argues the significant impairment to health. It's just, what is that in an athlete? Is it you don't have to be near death to be allowed to take a medication, so nobody's ever not being given a TUE because the impairment to health was not clear enough. What you do need is you need a very clear medical diagnosis with clear medical evidence and backing information. The return to normal health, talk with a philosopher, what is normal, right? We tried to fix some things. We tried to move it. We do have now a comment. I don't think it's terribly much more helpful, but it's the idea that normal health is the health in which the athlete, the normal condition in which the athlete was in prior to requesting the medication for which a TUE is sought. So I'm not sure if that helps anything, but we certainly worked at it quite hard. And then the last thing I'll just talk about is this business of the fairness. There are just some times where somebody should be granted a TUE and should not be sanctioned, but the rules don't seem to allow it. So we have this, I guess it's an escape clause, which makes me uncomfortable, makes everyone comfortable, but it's just the right thing sometimes. And this is the idea that you just sometimes cannot fulfill the other criteria for a TUE. And I'll have to give you a couple of examples just to show you where we're at. Somebody goes to a major games, sees the doctor that is now employed by the major games organization, is given a glucocorticoid injection for a sore shoulder, but not kind of an intrabursal, which would be allowed, but gets it right in the muscle, gets an injection. I don't remember it was in the where in the arm, but it was given that kind of an injection. that was wrong. It's not, that was prohibited, and in many ways, it got to the TUE committee and they say, no, this is wrong. We should not get this TUE for that. So if that TUE was denied, because it does not fulfill the other criteria, there was other ways to have treated that, better ways, this athlete would have been thrown out of this games and sanctioned. So it's sometimes you have to have something in the books that will just allow for those conditions. And again, I think it's important enough to mention another case where, again, an athlete going to a Paralympic Games, multiple medications, trying to control hypertension, there's kidney problems, and at some point they're modifying the medication, and at one point she ends up on a combination antihypertensive that included a diuretic. And the diuretic was prohibited. Somebody says, well, you know, there was other reasonable permitted alternatives, that she should not have been on that one, and therefore the TUE is refused, TUE refused, there's an ADRV, the athlete loses the medal, the athlete is sent home in shame. I don't think that was the right thing to do. The athlete, you know, yes, we don't want to just say blame the doctor, that's not an easy way out in sport. In this case, everybody, including the people sanctioning the athlete, felt that this was wrong. So those are a couple of examples. I'll stop here.
Well, no, because Madeline was, I think, responding in brief to some of those points. So over to Madeline.
I'm really interested in this whole idea of the kind of return to normal function. And I had a comment for then and a question for Alan, if I may, which is, I mean, normal function can be physiological function, or in fact it can be behavioural function, which is very much what you were talking about. And in the equine world, there's an interesting difference again between regulators, that in the non-racing world, the FEI does allow the use of a synthetic progesterone, altranogest, which is, it basically suppresses estrus in mares, because some mares, their owners and riders feel behave abnormally, if you like, when they're in season, and that distracts them from their competitive performance. But interestingly, Ritalin is sometimes used by owners in stallions, anecdotally, to try and do the same for them, and that's not allowed by any regulatory authority. So that's kind of an interesting oddity. And as far as the return to normal function goes, the FEI does allow the use of omeprazole, which you'll know is an anti-ulcer drug, in horses. And the argument there is very much that, you know, the horses with ulcers, A, it's a welfare issue because they're in pain, and B, it's making them perform suboptimally. And so they allow it because the omeprazole, in their view, simply returns them to a level playing field with horses without ulcers. But we don't generally extend that argument to the use of painkillers. So the use of painkillers during competition isn't normally allowed. And part of the argument against it is that we shouldn't mask pain to such an extent that the horse can damage itself. So if, for example, it has an orthopedic injury and we take away the pain, it might damage itself further in the course of competing. And my question for you is, when you're considering TUEs, do you ever consider whether enabling the athletes to compete is likely to expose them to harm?
Yeah, I mean, that's one of the criteria, you know, why things go on the prohibited list. So it's more of, should this be prohibited or not? And then if it is prohibited, then you may apply for a therapeutic use exemption. We got asked a question recently about Xanax and why we allow Xanax in some sports. At some point, you have to be practical. So sedatives, anxiolytics, and for the vast majority of pain medication are not prohibited. And if you just can imagine trying to control that in the world of sports, where we find that athletes who go there with bad injuries, and you know, Canadian hockey players who play through with a fractured foot, they're heroes. We celebrate these people. They push too hard, there's no doubt, but there's not another person who's actually giving them the medication. They're asking it for themselves for the most part. And I think actually, if you ever looked at the initial IAAF, I think it was the first anti-doping rule ever written, it was in 1928. If you read it carefully, it doesn't actually say that the athlete should not take stimulants, which was the substance. It says that nobody should give the athlete the stimulant. So that was maybe more like the veterinary medicine back then.
Well, that brings us right back to Susan's first point about consent. I guess that's the difference, yeah.
So I do have a comment on harm to the athlete, because it comes up for, in the professional organizations in the selection of medication, where if in the TUE process, when a stimulant is recommended and the choice of the stimulant allows us to look into, is the stimulant use appropriate for the athlete? And there have been a couple of instances where I'll anecdotally give a couple of cases where it hasn't been. We just had one come up where this was a TUE reapplication where the player had had a TUE previously and had lost substantial weight actually on several stimulants, 20 pounds, and on several stimulants, and it was coming up again for a different stimulant, and it was deemed not appropriate. You know, that the player may have ADHD, and that was in question actually in the TUE, but actually the issue was that the medication in and of itself may have been harmful to the player because of substantial weight loss. We see this sometimes in hypertension, and if there's a noted history of hypertension, the TUE can be delayed, and we've done that decision until the hypertension's treated. Because again, if we look for again, put the emphasis on the correct diagnosis and the correct treatment, everything else follows.
That's a tricky one for our world because, again, we are seeing applications from around the world, different medical practice, different viewpoints. And sometimes when you're working with a league, the TUE area can kind of blend a little bit to the good medical practice that you're trying to institute around the league, which I think is a great thing. In our world, sometimes we just say this is a clear diagnosis. The TUE committee may not exactly agree that this is what the best treatment is, but if it does fulfill the criteria, then the TUE committee not only will, but should grant the TUE. Every now and then, they may put a little statement on the bottom saying, which is kind of beyond their boundary, saying that, you should consider, reassessing the medical situation, and that the TUE committee does not necessarily condone this particular treatment. And we've had that with narcotic use in, like an equestrian person, and the TUE committee granted it, but didn't really like the idea of this person riding on a horse. Frankly, we all thought the person should retire, but that was not the call of the TUE committee.
We're going to have a comment from Mike, and then given that lovely point around, we've got people from all over the world and all different contexts within the room. We'll then open up to the floor after Mike.
I just added one thing, and that's about privacy, justice, and transparency. So the dominant medical norm is going to be medical confidentiality of the athlete-patient. Now, in the case of retroactive, I think my position, along with my colleague John Pike, is that the TUE is an exception, right? It's an exception that allows you to have a prohibited substance for good medical reasons. But a retroactive TUE is an exception to an exception. Now, then the question becomes, does justice demand that fellow athletes know who's receiving a retroactive TUE rather than a prospective one? And I think that's something rather like you said about the privacy argument over whereabouts. I think justice may demand, actually, fairness may demand that actually people know about that. Now, in between not knowing anything about it and having full disclosure of the symptoms and the condition, there probably is a happy middle ground, because I think it would do a lot to quell perceptions of injustice if they knew who was receiving retroactive as opposed to prospective TUEs. But that's something you really want to hear about from the athletes.
Any athletes in the room want to respond to that?
Steve, you're an athlete still?
No.
Oh, yeah, sure.
So I just wanted to comment because, just some background.
Yeah, can you do, that would be perfect. Introductions, name and where you come from. Thank you.
Steve Elliott, I worked at Amgen, spent my career working on erythropoietin. So the premise of this discussion is very different from the premise that I came from as a scientist at a biotech company. I would get asked, why did you not become more concerned about erythropoietin when you were in the early development, concerned about doping? And why wouldn't you put a substance in the vial so that it would be easier to detect abuse? And I didn't answer the question that way. I said the perspective and perception of this is wrong. The purpose of these drugs and the people that are developing them is to make people's lives better. Doping is just something, unfortunately, that is a side effect that some people will abuse the drugs. And I think we're starting to get into that discussion a little bit, but we're not really approaching why we have medications in the first place. It's to treat pain, it's to treat diabetes, it's to treat anemia in the case of mine. And I was just reflecting as we were going through this that I suffered from back pain, had surgery, and about a year ago I was in so much pain, I could not sleep, I could not stand, and worse, I could not golf. And so I had a dose of high-dose corticosteroids, and it was life-changing. The pain went away, and I've been pain-free since. And I was just thinking, Tiger Woods just had 4 back surgeries, and he couldn't play because of back pain. And I could identify with what he was going through. And what if he had taken corticosteroids to treat his back pain, and it was in excess of, just treating the pain, but it actually gave him the benefit that corticosteroids could do? Would we look at him differently because he cheated?
Yes.
Yeah, but he could, it's your perspective on it. The purpose of the medication was not to cheat. It was to treat a condition under which you could not live a normal life, in my case, without.
I mean, I'm not going to be the person on record talking bad about Tiger Woods, but I will say that there are people who do question the performance and after what he's been through. And that's just a fact, right? Like, some of the things are beneficial to performance. So some of us athletes, we do question it.
So, can I just ask if you took the anti-Tiger woman? Now you're labeled.
I'm not.
You're labeled. So if he took a week of long glucocorticoids before the competition, do you feel that would have given him an advantage if beyond what he would have had if he had not had the injury? Because that's the whole point of this.
Right.
I mean, you may say yes. I'm not trying to badger you into anything here.
I think it's complicated. I want to say, no, it's not an advantage. He needed it. Clearly, he's in pain. But there's also a part of me that says this is just the reality. Some of these things, masking pain and I don't know. I feel like I'm on the spot. I feel like I'm going to be that girl. But yeah, I think there is benefits to masking pain and doing things like that. I mean, I'm a track and field athlete, and I've gone into competitions totally dinged up where I shouldn't have been competing. And it was a benefit to get a shot that allowed me to compete where I probably shouldn't have been.
Got a shot of what?
What we're talking about.
Generally, if I may say, because this is an important part, generally you're not going to get a TUE for an oral glucocorticoid or an injection of a glucocorticoid in the muscle to allow you to compete.
Yeah.
So, and because if it was up to me, I'd probably be letting it go because I don't believe there's a whole lot of evidence that it's performance enhancing. So if it was up to me, I would be swinging much more leniently. But because of athletes and others who are concerned, we generally don't grant. We'll, if you get it directly into a tendon or to a muscle, into a joint, that's allowed. But if he would not be allowed. And personally, I think I would have been okay if Tiger took glucocorticoids right before, but it would probably have, his TUE would probably be rejected.
May I just ask you a question, which is, would you be happy if you knew that whatever athlete it was had had treatment in between competitions, okay, but you were utterly confident that on the day of competition that was no longer having an effect? So in the black back analogy, you had your glucocorticoids and now you're fine, but you're not still having them as I understood it. So would you be happy with that in your mind?
Yeah. I mean, I think you
and
have to have room for treatment, right? People get injured, people need help, people need surgeries. Yeah.
And that's very much the horse racing authority's view, is you can treat between competitions, but nothing has to be in the system during.
I had a question for Dr. Adler. I'm Bonnie Ford from ESPN. You have a great number of athletes flowing into your sport, I'm sure, who have been medicated since they were young children with ADHD and other similar types of medication. As we all know, in the United States, it's just massively, some would say, overprescribed. And there's a psychological dependency that develops in some cases. Then you have a whole different population flowing into your sport from Latin America, let's say, where that's not done. How do you consider that history when an athlete comes under your bailiwick and he has been medicated conceivably since 6 or 8 years old, and perhaps with forethought about, I want a college scholarship or I want to be a major leaguer, then how does that play into the evaluation once they do become a major leaguer?
So let me take the low-hanging fruit first. For the Spanish-speaking players, they are evaluated by Spanish-speaking clinicians with structured evaluations, and we feel that they deserve the same type of structured evaluation that the English-speaking players deserve, and they receive that. I don't have data to support this, but let me deal with the issue of overprescription and the impact of that. Certainly, the issue of overprescribing is certainly out there. Some of the data on overprescribing comes from overprescribing doesn't mean overdiagnosis necessarily, though, because some of the data on overprescribing comes from the CDC survey. And the CDC survey is a simple question, which is a question that's been asked of parents that says, have you been told by a physician that your child has ADHD and has been treated? And that's not the same as a diagnosis. So when we actually go into the field studies that have actually looked at this is going to get a little technical here, and it's the only way I can answer the question, and then I'll get to the actual point on how we handle it in baseball. But when we actually do field studies of children with ADHD, like the Smoky Mountain study, that actually go and have trained clinicians go out into the field to actually look at diagnostic rates of children with ADHD, they're much lower. Now, does that mean that there isn't a problem that prescription rates of stimulants are higher and are growing? No, that's a problem. But that doesn't necessarily mean that our diagnostic rates of ADHD, the true diagnostic rates, are necessarily growing in and of itself. There are different questions that we're trying to address. There's a problem there that we in the ADHD field need to address. Do you understand where I'm trying to be nuanced in how I'm approaching it? That being said, for baseball players, and this is true in working with adults with ADHD in general, even if they've been diagnosed in childhood, most adults with ADHD do not regularly take their medication from childhood. There is most individuals with ADHD coming into adulthood have a substantial gap in their treatment. In the general population, adherence rates for ADHD treatment is terrible. So when we see a player that has come in that has been diagnosed previously, we look at those treatment records. We take those treatment records as part of the evaluation. That's critical information for us. However, if there is a gap in their treatment, that's critical information for us too. Because we look at what happens when there's a gap in treatment in terms of the persistence of the disorder. The science is that neurodevelopmentally, in terms of the imaging studies we have, there's a lag in brain development that occurs in the prefrontal cortex for individuals with ADHD up to the age of 26. So ball players that are coming in prior to the age of 26 still have ongoing brain development that's occurring. So we have to be cognizant of that in terms of evaluating their ongoing symptomatology. We want to be sure that they have the diagnosis before we grant them a TUE. And we want to be sure that the diagnosis is correct in terms of gathering all the information possible, taking into account their prior diagnosis, but also their current symptoms, current impairments.
Quick follow-up, how much research has there been on the health impacts of someone taking that type of medication who actually doesn't need it?
So there's been some data that have looked at that. So there was a recent study looking at rates of psychosis for individuals who are taking stimulants. Those rates are actually somewhat lower. You know, it's ethically a very difficult thing to do because you have to examine individuals who are taking medication for a non-approved disorder. So you have to look into the community in terms of what happens. In terms of the safety of the medications overall, we know the safety profile. The risk of psychosis is limited, and it's in the warning, and it's there. And that study that just came out showed that it's potentially true, and psychiatrists seem to see it less than, have it occur less, at least in that study, than primary care physicians. But the major risks of the stimulant medications, in general, whether you have ADHD or not, relate to potential cardiac effects, which relate to changes in blood pressure and pulse, which on the average are relatively minor, but they're average changes, meaning that some people have more, some people have less, and for the elite athlete, if there's dehydration, that can be an issue. So therefore, the average change that we see is about 3 points in blood pressure, five beats a minute in heart rate.
Yeah,
A question, a response from Len, and then I think we had a question here, and then we have a
Yeah.
question there.
I just want to mention, we talk often about this overdiagnosis of ADHD, overdiagnosis of asthma. There no doubt is some, but there's also underdiagnosis. And that's a critical thing. And as some people who are not taking their asthma medication properly, and people who don't take ADHD medication who should, is a serious problem. And I think Len could talk about it. And I think he wants to. Good. There's increased injury rate. It's not, you're not just gonna, oh, I'm gonna miss the final because I didn't get my act together to show up on time for the final of the 100 meters, but increased accident rates, increased injury rates. So it's a serious thing not to treat these people. And same with asthmatics. And you know, anti-doping, we're supposed to be about the health of the athletes. So this idea where we're starting to get a point where people are afraid to take their medications, and God forbid, because they're even going to have to tell everybody that they're on the medications and be under suspicion, is a serious problem. So
Yeah, I think, again, getting back to the right diagnosis for the athlete and the right treatment, the risk of missing the diagnosis is substantial. There's a higher, the risk of injury is greater, the risk of accident is greater. If you look at overall data from the Scandinavian registry studies, motor vehicle accidents are greater, early death is greater, in untreated individuals with adult ADHD. So it's not a benign disorder to ignore. You know, it's a disorder that if for individuals who have it, you know, it merits treatment. And the other thing that we forget sometimes is that a lot of our ball players are below the age of 26. And the one thing that influences persistence of the disorder is loading of symptoms. That's the only thing that's been found to influence, is the disorder going to continue? Because we have a developmental disorder here. And the lower your symptom load has been if you lower that, then you have a greater chance of the disorder not persisting. So if you deny treatment, you're in essence saying to the individual, I'm going to increase the chance that your disorder is going to persist.
Hi, it was a great talk from everybody. Gary Green from PCC and Major League Baseball, and I also do TUEs for USADA. I think, Alan, I'm really glad they took out the impairment to health part, because I always struggled with that. Like if you have, let's say a female athlete has severe cystic acne and has tried every other drug and now is trying spironolactone, is that really impairing their health if they have acne? But it does impair their social life and things like that. So I always struggled with that. I think the bigger question, I don't know if Mike, if you want to answer, is the Paralympians, because I think that to me is those are the hardest ones to deal with because they're on multiple medications, and most of them, or many of them, would not be able to compete without the medications, you know, at all. And including some of them on major narcotic doses for phantom limb pain or things like that. So that, to me, that's a struggle. I don't know if you guys wanted to comment on that at all.
Yeah, I'm very glad you raised that. Let me start by picking up on Al, who gave us two very good examples, but they were both physician errors. And the fairness clause, it might just be that the only cases you ever use this are in the case of physician error. So write a rule about physician error, rather than having a general clause.
It wasn't physician error in the second one.
No?
I mean, he just, physician error in the sense he didn't give the didn't ask for a TUE, but it was the right medication that the doctor was trying to give.
So it's we can't put an excessive burden on athletes to be double checking their physicians. And where you've got polypharmacy in the case of para athletes, I think there is good grounds for being more lenient in the application of the rules. The case I gave from the IPC was a very discrete one, and I guess it's quite unusual that the medication would so usurp the integrity of the competition that they denied it, and that's an exception. And I'm prepared to go with that. And I think you need a person with far better medical credentials than me to give a more informed answer than that. I think an in-principle answer is, and I think everybody around this forum is clear, that athletes have a right to healthcare. They shouldn't have to surrender that just to be an elite sports person. But there are nuanced discussions when that right to healthcare doesn't necessarily issue in the prescription of specific drugs. How you get optimal treatment, I don't know about that one. Is it adequate treatment? That may be a good enough bar. And that may rule out the perception by other athletes that the system's being abused. It may.
I mean, you also had the case in Sydney with the Romanian gymnast who was given Sudafed by the doctor and lost. I believe she lost her medal. I don't know if it got reinstated, but
Andrew Raducan, she lost her medals. But just to go back to the Paralympic, it's a good thing that you brought it. It's the rate of TUEs is about 3 to 4% as opposed to 1.5. Often extremely complicated polypharmacy, as you said. And if you want to really get to a tough case, there was an Olympian, not Olympian, but a shooter who had congestive heart failure, went and was denied his TUE, went all the way to CAS, and the CAS upheld the denial. Then there was another athlete, muscular dystrophy, I think it was 26-year-old, Paralympian, was on a beta blocker, heart failure, massive heart failure, couldn't sit up without braces, had to have his rifle held up. Clearly the only sport in the world that he even had a chance of doing. And we encouraged him to go back to CAS. We didn't, we kind of sidestepped the decision here at WADA, partly because of the precedent. And the guy went to CAS, and he was the refusal by the IPC was overturned. And partly because they said, we're not sure, considering this fellow's muscular dystrophy, in this particular case, is this something that is going to harm the fairness of the competition? So he was granted it. But, I mean, these are tough cases. There's no way around it.
Yeah, I was just going to make a comment. So I'm Sam Lima. I support 2 Major League Baseball teams, EAP, also a licensed clinician in the state of Florida. And one of the things that I have seen, though, when we talk about the Latin players, that they don't have a history, obviously, because of their structured. It's not the same as in the U.S. So therefore, when they come to the States and we look at them for the potential ADHD, the costs involved prohibits, and most of them will not follow through or get that because it's considerably anywhere between $4,000 and $5,000 by the time you get through the TUE process, between the testing and the cost of the psychiatry, and then you have almost $300 a month for the medication. So that makes it really almost impossible for that group of people to actually have that support.
So you're talking about the minor league process there,
Yes, sir.
which is different than the 40-man process that I was discussing. So in that and I'm not particularly discussing that today. Where we're talking about the structure of the 40-man process. The cost of treatment is something, it's a completely different issue, and the cost of the evaluation is another separate thing. Getting this done right can be an expensive proposition, and
I'm not questioning the process. I think it's excellent that we have that process. I'm just saying that because of the situation on the minor league players coming up the system, it's just not, the equity's not there.
yeah, I think we're doing what we can to try to gather the information and try to make it as available and accessible as we can. And if we have barriers that are created, or if you have situations where you can't get it done because of cost, we need to hear about it. So.
Yes, thanks everyone it was a very interesting panel. I'm Bertrand Stoffel. I'm with the McGill University Faculty of Law and Institute for Health and Social Policy. I don't want to put words into people's mouths that weren't there or didn't and overinterpret what came out of the discussion, but I was under the impression that there was some sort of agreement that at baseline athletes shouldn't be denied a treatment that they would otherwise have access to just for the sake of being an athlete. And I understand that's an ethical, that's not particularly ethically dubious, and I would say this is also what prevails in clinical trials and in many other aspects of life and society. So throughout the discussion, I still felt like there was a need, and some people felt the need to justify that baseline. And the question goes maybe particularly to Alan, but to the other panelists as well. What are the reasons that bring or make you feel like you have to justify even that baseline value or you've several times you've expressed the need to justify the fact that athletes shouldn't be denied treatment just for the sake of being an athlete. Is that why would you need?
Why do I need to? I think I'm responding to the questions that are coming. I mean, I don't normally, a few years ago, and I think before 2016, I wasn't going around saying, why do we need TUEs? It was just, to me, that was just as with many of the physicians, and as Steve Elliott said, that this is medication, this is good medicine, we're treating patients. People are being treated, and that's the system. Now, because it's the world of sport, athletes are held to higher standards, sometimes almost impossible standards, but they're held to higher standards than elsewhere, and therefore, if they need medication to make sure that there's fairness within the world of sport, we have rules in place, and you cannot just simply come up and get a doctor's prescription and get an exemption. So, and I think that's correct. Now, people actually think out there that all you need is a doctor's note, and please excuse Mikey who wants to play tennis and has a medical condition, and give the note, and he can take this medication. That's why I say we have a robust system in place, and I think that's right. Where we're really talking about just a fine line. I think everybody's pretty much in agreement. And just when you're talking again about EPO and how many applications do you think we got for TUEs in all the Olympic Games for testosterone use, for EPO, for anabolic steroids over the last, let's say, 20 years? Anybody has ideas how many applications we received? No, zero. I mean, there's not.
Everybody knows they wouldn't get one, so why bother applying?
Which, therefore, the system is reasonable. I mean, there was one case, interesting, we almost had our first one, and it was somebody, I don't want to say too much about the case because I don't want to break anonymity, but a ski jumper, we'll give that one, and his brother was already competing, was on the Olympic team, and then this younger brother who had a medical condition that required the use of testosterone, which actually was one of those rare legit ones for testosterone, because we're very strict on that. And then, sure enough, he was granted the TIE by the National Anti-Doping Organization. We looked over it because we were very careful with testosterone TVs. And we actually surprisingly found that it was a legit case, but the guy never made the Olympic team. You know, and that's more typical. It's not the one who took the testosterone who's the star athlete. That's the one that probably has a problem and didn't even get back up to probably what would have been normal. So
We had an NCAA case with Kleinfelters.
Yeah.
Legitimate
Yeah.
case.
well
We have
done.
a question here, and then we're going to a question here, and then I'm with the questions. Thank you, everyone.
Athena Brindle from Texas Tech University School of Pharmacy. So a lot of the stuff that we're talking about, like pain management and ADHD, even with the criteria, the diagnostic criteria, it's very subjective. And so that's why you need specialists, as Dr. Adler has, with the psychiatrist. So in that case, we mentioned cost. Do you think it would be in the best interest of the sports team to invest in those specialists in order to increase the validity of the diagnostics and maybe decrease the misuse of the medications?
The question's for who? Can you answer that one?
I'll answer it generically. I think it's important not just for the team, but I think it's important for the organization as a whole. It's not a team specific, and again, it's the emphasis on the athlete. It's getting the diagnosis right, getting the treatment right, and then it all flows. And there aren't shortcuts here. You have to. The investment is worth it.
And from WADA point of view, we emphasize as much as possible, whether it's again a asthma diagnosis or ADHD, to go and see the absolute best specialist and a high quality. But again, it depends where you're living, so we have to live with that. So it's always a challenge. And I say where you're living. I'm living in Montreal. Try and go and get an appointment with a psychiatrist in Montreal in a few months, including sometimes the Olympic athletes. It's not the easiest thing. Sometimes it's just accessibility, not just cost.
Can I just add one little comment to that? Would be the question of who appoints such a person and who pays for them. Because one of the really attractive things of your system is the independence of the psychiatric reviews. And a knee-jerk reaction might say, well, we can't afford that. But then if you take a look at rugby's response to the concussion problem, I mean, they have been dragged kicking and screaming to the table where they now do have independent head impact assessment. And that's clearly a gain in athlete welfare. But that's only happened because of the independence. So the function's critical, but the independence is, I think, absolutely essential for athlete welfare.
I'm Richard Holt. I'm Professor of Diabetes and Endocrinology at the University of Southampton and was involved in the development of the growth hormone biomarker test. So my question relates to the use of hormonal treatments in childhood that clearly could have very long-term effects in terms of performance. So, for example, growth hormone is used for not only growth hormone deficiency, but it's used for short stature without any hormonal deficiency. But of course, those children who receive that medication may end up being 10, 15 centimetres taller as adults and therefore are able to compete at an elite level, which they would never have been able to do without that treatment. Often this treatment is started well before they reach elite level, so they will not necessarily have any restrictions placed on that use of medication, and yet long term it has a major effect on their performance. And I just wondered if there are any comments about how this may be regulated, what the ethics around this, and whether we should be thinking about at least considering the long-term effects of medications used in childhood.
My deep concern in terms of justice would be that to take any measures might well be a case of victim blaming, because the child is going to be disempowered in this process. And so where you've got the pushy parent syndrome moving toward this, and we all know that there's a very famous footballer in the world, perhaps the most famous footballer in the world,
he was on my mind. But I think under that situation, it was also the club that actually was very much involved in providing that treatment. So they were, in a sense, they had a very marked conflict of interest there in terms of creating the best player that they could.
So it's one of those unfortunate areas where everybody knows something wrong is going on. But to try to develop a regulatory system which doesn't punish the victim of it is exceptionally difficult. But certainly it's something where further consideration is needed. And it would be the same for any kind of genetic manipulation, which people are talking about a lot, but which there isn't any great evidence of. if it's going to be effective, it's going to happen, the intervention is going to have to happen in childhood or pre-adolescence or early adolescence. And these are times when, you know, all things considered, that individual is not competent in making decisions and is inherently vulnerable.
The other thing that interests me is it's not just medications, is it? It's surgeries as well. So in the equine world, for example, we sometimes have foals born with angular limb deformities, wonky legs, which are corrected surgically at a very young age, and they may go on then and compete very successfully, and they probably wouldn't have done so if the surgery hadn't taken place. And more in the equine world than perhaps in the human world, those animals that have competed successfully, having had the surgery, might then be used for breeding and might go on to breed more horses with wonky legs, and then we do the whole thing all over again. So it's ethically interesting.
We can start going off into the world. There's all of the surgeries. Is it correct if you have correction myopia, but you go beyond better normal vision? Breast reduction, what was your norm before? So, you know, you can really start to go wild on this. And then all the genetics, you know, in utero gene editing, and how do you blame the athlete later when still an embryo at the time the decision was made? So they certainly can't, it's not going to get less interesting. We'll still be needing your help to deal with these, Mike.
Yeah, thank you very much. Richard Budgett from the IOC, fascinating conversation. I always reflect and say that doping is fundamentally a threat to athlete health. And so that's why we're talking about athlete health here. So, I mean, I'd be interested in your views on, with therapeutic use exemptions, we're always tempted to be dragged down the route, and you've touched on it, of actually trying to promote good medical practice for athlete health. But do you think that's the role of the TUEs, to promote good medical practice, to police medical practice, or is it actually to ensure fairness and the competition is fair? Because at the moment we resist as much as we can being dragged down this route of enforcing good medical practice, but it's a difficult line.
Yeah, that's a brilliant question.
I mean, I kind of alluded to earlier where I thought it's really not, we cannot control medical practice entirely, and that some of the organizations like UCI, they have one division that talks about good medical practice, and then there's another one which the TUE, which was fairness, and it's just at some point you have to limit yourself. But I'll let Mike expound on this.
Yeah, that's a really great question, and if you're going to explicitly foreground the role of a TUE committee in terms of this ethical component, then you're going to have to reconstitute TUE committees with people who have expertise in it. But anti-doping would be a different affair if national medical associations with licensing powers took anti-doping more seriously. I mean, if it was something for which you could be struck off explicitly, that's going to sharpen the minds of physicians who might be tempted to use the arbitrariness of some kind of diagnostic criteria to afford a TUE where it shouldn't be. Again, I want to say what Alan has said all the time. This is very rare cases. This is not the norm. But the more general posture, I think, is going to be, when will national medical associations take anti-doping more seriously? And if they were to, then you might think, actually, advising them on best practice in relation to doping-related diagnoses and so forth would actually be a very good thing. But I don't see why WADA might not suggest norms for good practice. In between being able to control those regulatory powers, which they don't have and never will have, they could still make declarations about good practice, some consensus statements around how to operate these. So there may be something in between just being laissez-faire and knowing that you're never going to have the power to change a national licensing authority in medicine.
I sort of see it that the boundary falls when the selection of the medication is influenced by the medical status of the athlete. And then I feel that the TUE has to make some statement if there's, because the TUE is ruling on the selection of the medication, at least in baseball and in football. And therefore, the committee is making some statement about the appropriateness of the selection of the medication. And in that context, it brings in the medical appropriateness. Most of the time it's not an issue, as it's been raised, but I think to ignore that piece of it when there are issues. And I mentioned one case, but hypertension's another one that we've seen. And, I think would be like sticking our head in the sand. I think you can't fully do that.
I think there's also a limit to what can be expected from WADA. And the sport medicine groups are out there, and they have a duty to regulate the sport medicine in their countries. And then occasionally with WADA, and thanks to Richard Budget, we've actually gone to you guys and ended up with this IOC consensus symposium on pain management. And that came out of discussions with WADA, and you have a number of those consensus symposia, and they're fantastic. And these are the areas where trying to guide good medical practice around the world. And that's an extremely important point, but at some point WADA has to, we have our limitations. We're having a hard enough time doing our own business, so we can't fix everything.
We've got 2 questions. We've got 3 minutes in order to allow Len to get away and get home. So we've got a question here and a question here.
Great. Thank you, everyone. My name is Matthew Kaiser. I work with Global Sports Advocates. We represent athletes accused of doping, and I just want to first commend Dr. Vernec for, we've had a TUE rejected by an international federation, and then the WADA TUE committee overturned it, granting the TUE. So, for any one thinking that it's just a rubber stamp, it's not. It's an objective criteria that's observed. But one of my other questions is regards to the fairness provision for retroactive TUEs. Is there any change, I don't know if you alluded to it, in the new code that's coming up for the fairness provision? And we've seen it granted kind of inconsistently between international federations, where the International Tennis Federation granted it on the fairness grounds for a student who had ADHD, who was taking Adderall. We've had one where we submitted it to the International Equestrian Federation, and they've rejected on very similar grounds. So I don't know if you can comment on the inconsistencies or what's being done to harmonize everything.
Try and be consistent. But again, it's case by case.
Sure.
I know one of the odd things, we talk about retroactive TUEs, the NCAA, the largest sporting organization in the world by far, does not require a TUE in advance. So I know we had, I don't know which case you're referring to, but we had a case of a tennis player who did not put his TUE application in advance and stated that he was fulfilling all the NCAA requirements. He kind of suddenly moved into national level competitions, and then it was being refused because he should have done it in advance and he didn't have it. So there's cases like that. We try to do it, but there's always going to be some situations where I imagine there's going to be some, again, on the edge, that this one you could be granted and this one not, and it depends on the committees, depends on the lawyers, and like I said, but we do want to be as consistent as possible. And I think the fairness, the difference in the new fairness, if you read the one now, it basically says this is the criteria you need to be able to apply for a TUE, at which point you must now fulfill all of the 4.1 criteria about, do you have a medical condition, is there a performance enhancement. So that's how the 4.3D is now, the fairness. In the new one, it's going to just basically say, in some cases, it would be manifestly unfair to not give this athlete a TUE, and it is a possibility that they failed one of the other 4.1 criteria, meaning there was another medication that they could have used. So it kind of clarified that. It's going to be something that we're going to monitor like crazy. I'm sure we're going to be asked by people to make sure that this system is not being abused. And again, I think it'll be used very, very rarely, but we'll see how it goes, and we will work with our stakeholders in making sure that they understand how it's being used, and we'll try and find ways of being as transparent about the system as possible while respecting the anonymity of the athletes, and it's not always easy.
Yeah, hi, Sam Paul here from UK Anti-Doping, the TV administrator. So firstly, thank you for your time and discussions during the ICTV consultation. Perfect follow-up question to that around the fairness. We heard in the morning session today about transparency in the system, and trust in the TUE system is vital for external validity. So the proposed amendments to that clause is that an application can be granted without needing to fulfill all of the criteria for granting a TUE. Now, could that lead to concerns over the decision-making process? You alluded to enhanced transparency. Could it be an improvement if WADA were to publish on an annual basis how many retroactive TUEs were granted under that provision? Because we've moved to, taking Mike's analogy of a retroactive TUE being an exception to an exception, this clause is then an exception to an exception to an exception.
I've never bought into the exception to exception. It's just a matter of timing. You have a TUE application, you have a medical condition, you grant a TUE, or you don't grant a TUE. So, as clever as the exception, it's a TUE. Now, the business of being transparent about that is we have to find a way, and I understand what people are saying, and I think we'll look into that. I think it's a good point. Again, people then next thing is like, oh, there was 6 of them. Which countries? Can you tell us the countries? And next thing you know, somebody's figured out that it's this, this particular athlete from France who now has this particular TUE, and we're trying to respect that. But we hear you on this, and I think we're going to be questioned. So I think that we have to find a way to show that the system is still solid, and that we can provide some of that information.
Do you want a final point, Mike, before we come to a close?
Well, I was just thinking if you missed the doping control officer because you were an hour or two late or the wrong day, and the athlete says the doping control, and it's just about timing. I don't think they're going to be impressed about that. So that reconceptualization of the issue is just about timing. Maybe. Not always.
If you're escaping a whereabouts, it's because you may actually be trying to avoid a doping test. The business with a retroactive, again, if it's
you might do that with retroactive TUE, because you might say, I don't think I'm going to get into the contest, I don't think I'm going to get into the final, I don't think I'm going to get a pump, so why don't I just try my luck? Yeah. So it could be worked the same way, couldn't it?
People do that anyway.
So that we finish on time, Isabel's here, ready to cue us up. Please, can you join me in just thanking the speakers for a really